Hello all, my name is Ufuk Wardar. I'm one of the second year cardiology fellows at Mayo Clinic, Florida. It is my honor and pleasure to have Dr. Saibal Kar, PI of the Champion AF trial. Dr. Kar, thank you so much for coming. So I'll read the conclusions of the study and we can move forward with questions. So then among patients with atrial fibrillation who were candidates for anticoagulation, device-based left atrial appendage closure was non-inferior to NOAC therapy with respect to a composite of death from cardiovascular causes, stroke, or systemic embolism, and was superior to NOAC therapy for non-procedure related bleeding at 3 years. So, Dr. Kar, how does this affect our clinical practice? What do you think the future is after this seminal study?
Thank you very much for inviting me, and this future is good for people like you, since you guys are going to be the future. The journey of closure, left atrial appendage closure against medical therapy has been a long and hard journey going up. And what I found on that journey is the incremental benefits of this procedure with improvements in technology, improvements in doing the procedure and taking care of these patients. And we started initially, remember, with patients who are high risk for bleeding, and now we've gone into a real place, a real world where people are considered to be candidates for bleeding. Now, the reason why the study was done was, as you remember, the original studies was against warfarin, right? But we found out only in the last decade that warfarin is not the standard of care.
Yes.
So we thought the most reasonable thing to do was be doing a large scale compared to the standard of care today. We do now know that from multiple trials that NOACs is the preferred treatment for the prevention of stroke in patients with non-valvular atrial fibrillation. Left atrial appendage closure was only approved or is indicated for patients who cannot take. So the big question is, what about people who can take and who don't want to take it? And this is what that study was. As expected, we obviously took patients with low risk of bleeding. Because people with a high risk of bleeding, it became unethical or non-equipoise in randomizing those patients, right? So we actually took a risk.
Yeah.
We took a risk of not winning on bleeding and actually showing non-inferiority of stroke. So that's why we had two different endpoints, one for the effectiveness and the second one for bleeding. And there's going to be a third primary endpoint which has not been announced as at 5 years for only ischemic events.
Absolutely.
So I think it is very encouraging with this data that we definitely have shown that there's a significant increase in bleeding, especially clinically relevant bleeding, at 3 years, 19% versus 10. And if you look at the composite endpoint of efficacy, it was really 4.8 versus 5.7, which was within the non-inferiority margin. So we think it's reasonable. There was actually, if you look at the composite analysis, there was no difference in deaths in the two arms. There was no difference in hemorrhagic strokes, and that's expected because NOACs prevented hemorrhagic strokes compared to warfarin. But there was a slight increase in ischemic events, which was as 3.2%. And if you look at all ischemic events on the medical arm, it was 2.2 if you include systemic embolization. So the difference is only 1% over 3 years, which is an annualized difference of only 0.33. And we are hoping that this will stay the same over the next 3 years, or next 2 years to follow. And in that case, then we'll feel comfortable about this results.
Thank you so much for the comments. What do you think the difference of this trial with the recently published Closure AF trial from Germany?
So the Closure AF trial was a pragmatic study, trying to compare the whole concept of LA appendage closure versus medical therapy. Now, there are some things about this trial which bothers me and everybody. They had 10,000 patients which were screened, and they managed to get only 900 of 10,000 patients over a period of 6 years, which becomes a problem of whether this is even a practical study, right? That's the first. Second is, because it was done over 6 years, they had 4 generations of devices. They had 4 different classes. They included the older generation Watchman device, which has slightly different safety results, right? Third is their complication rate. And the biggest problem to me was the upfront complication rate of the procedure. It was 6% in 7 days compared to only 1.1% in this large randomized trial. And this 1.1% is identical to the ACC NCDR complication rate of LA Appendage, which is over 60,000 patients. So what they got seems to be out of proportion. Once you have that degree of complications, it's difficult to make up in 3 years, right? So that's the problem, I thought. But the good news is the stroke reduction was identical in both the groups. So I think the concept of LA appendage closure did come in that study also, but I think the reason why it was not non-inferior is because of the complication rates, which was primarily bleeding, as well as I think there was also some higher deaths also in that.
Perfect. And some folks are worried about sometimes device-related thrombus and peri-device leaks. Those are the two sort of feared things per se. What is your comment and your findings of those in this study?
So both of these factors that you mentioned are important. We start with peri-device leak. And initially, we didn't know exactly how much is significant, but the consensus seems, including a person, Dr. Kohli from Mayo Clinic, actually wrote a very nice paper on that, will show you that overall, if you measure a leak which is 3 millimeters or more, it is associated with a slightly higher risk of ischemic strokes. So in this study, we found that only 1.4% of people had 3 millimeter or more. And there was less than 98% had leaks less than 3. However, some people said that's also not perfect. It should be complete closure. And of course, we're trying to perfect that and understand it in more detail. And it does, I think you're right about it, that leaks do matter. Okay. And the good news is all these devices are iterating. The Watchman Flex is coming up with a new device, Elite, which is probably more conformable. The Amulet device has come with a new device called Amulet 360, which is more conformable. So things will all go in the right direction. The second one that you mentioned is device-related thrombus. And personally, I do feel that device-related thrombus does matter, even though the data has shown it. In our study, it was 4.8%, and this was the core lab reading anything layered on the device. So it was a little bit more sensitive than what is clinical practical. But if you look at the breakout of the data, there was only large peduncular thrombus, which we think are a risk, was only 0.9%. And around 1.4% of people, there was actually a change in therapy based on NOACs. That means the physician felt that it was an issue. And there was only 2 DRT-related strokes that we know of. So I think it is a problem. It's not gone away, but it's small. And I hopefully with new generations of devices, this will change. And another thing is that we think over time, the DRT rates will go down because obviously over time healing takes place.
Absolutely.
This was a snapshot at 4 months, right? If you do the same thing at 1 year, 2 years, it'll probably be less.
Absolutely. So my next question is about the follow-up imaging. Now that you mentioned CT versus TEE, that is a common question for folks who are doing. Which one do you prefer? And it has some pros and cons.
So I prefer doing transesophageal echo. And the reason for that came from the fact that in the original trials, transesophageal echo was preferred, right? And that's why that was the most gold standard. On the other hand, transesophageal is invasive, right? It's still invasive for the patient, and that's a discomfort to a patient. The CT imaging on that is a much more rapid test. CT imaging is easier for the patient. The downside, of course, is contrast. Okay, so these are the downsides. But the CT imaging, the problem with CT imaging, it's a slightly more sensitive. That means even if you have a leak through the fabric of the device, it'll show up as a leak. So it picks up a little bit more than is clinically relevant. So I tend to do in my place more transesophageal echoes.
Understood.
And the reason why I do it is because even if I see a leak, I actually want to measure it, I want to quantify it, and I actually want to see whether I can fix it. And then I need that. CT, on the other hand, doesn't always pick that up. It's a little bit more sensitive. Having said that, I believe that there'll be more and more people doing CT imaging because of convenience. and it's also comfortable for the patient.
And one other thing I realized is the 3-month regimen. So that's a hot topic of discussion. So in this trial, 85% were DOAC and about 12% was DAPT. What's your practice with that?
So this is a very important question, and this is actually unique to the design of this trial, and it might become standard care. This truncated antithrombotic regimen was actually only first time studied in this trial, right? There was some basis of that, but this is the real large trial which tested it. The imaging was done, as you can see, at 4 months.
Yes.
And there was a reason for that, because the original imaging plans used to be at 45 days. But in 45 days, the problem is it gives you a false sense of satisfaction that everything is good because the patient is still on anticoagulants, right? So you may not have shown a clot at 45 days, but it can pick it up later. That is the reason why we said 3 months and then wait for another month. And while the patient is only on single antiplatelet, then do an imaging, because that's the most vulnerable period. And that's why we did only one. And we did not do at the end of the year. You say, why didn't we do at the end of the year? The reason for that is in clinical practice now in the US, a lot of people are not doing the 1-year follow-ups. They were in trials. And that's why we just came up with this plan, which we think is quite practical. And this is something which people will do. And also it shortens the antithrombotic regimen post-procedure, right? So if you want to take advantages of bleeding, then you should truncate it. And that's why we did this, right? Having said that, there's a very nice study going on right now, which is completed, called Simplify. And it's testing the post-procedure regimen.
I understand.
There are 3 arms. One arm will get 6 months of DAPT. The second arm will get low-dose NOACs for only 3 months. And the third is just going to get baby aspirin from day 1.
Wow.
And we're going to see if there are any differences of outcomes at 6 months and 1 year.
Yeah, perfect. And lastly, Dr. Carr, what do you think the future directions are, especially guidelines? What do you think the recommendation now may be, and patient selection for Watchman devices?
So I think based on all this collection of data, the direction on the left atrial appendage closure for, at least we know in the US, the numbers are going up. They are just skyrocketing. It's probably one of the most rapidly growing field in structural and electrophysiology is L appendage closure. If you look at all health systems, and then I work in the ACA system, it is one of the largest factors is L appendage closure. What will happen, I think, is from the electrophysiological side, they will be doing more concomitant procedures. At this moment of time, 1 in 4 Watchmans are placed as a concomitant procedure. And this will tend to increase even further, especially making the safety and easiness of AF ablation. There'll also be a combination because we are beginning to realize that actually AF ablation may actually reduce the burden of AFib and potentially reduce the risk of stroke too.
Yes. Yeah.
On the other front, which has not been tested and should be done, is on structural interventions. Because when we are doing now a mitral procedure, 50% of the patients with significant mitral valve disease have AFib. And the surgical guidelines state that when you do a mitral valve repair, you close the atrial appendage off.
True.
This should be the same thing for us doing MitraClips or, transcatheter edge-to-edge repair. We should do a edge-to-edge repair, and if the patient is in atrial fibrillation, go ahead and close the appendage, because you're already there. You already have a TE probe down, and you already have a transeptal access, so there's no added risk. So I feel the reason why this is not happening right now because there's no concomitant code for this procedure for the cost, and I have a feeling that the first step is probably to have a concomitant code similar to what they have for AFib for these structural procedures. So those numbers will go up. Now, the second thing that you asked me is about where do we stand in guidelines and where do we stay in standards. I have a feeling data like this large trials like that, and there's going to be another one called Catalyst, will help in pushing the guideline status for left atrial appendage closure. At the moment, it's only status 2B, right?
Yeah, class 2B, yeah.
And I think that's not right. No, not right. It's based on the evidence.
Sure.
Now we have a very large randomized trial. We have option, and these two in Prague 17 I think all of them put together should at least be moved to 2A.
Understood.
And hopefully, if we get the long-term data of this study, Champion, and if you combine it with Catalyst, hopefully it should become in class 1. And the whole goal is to make sure that this is a reasonable alternative to take long-term anticoagulants. There is one other study which is going on, which is trying to show superiority of closure of the atrial appendage plus NOACs versus NOACs alone. And that study will take a longer time, but that would actually definitely also improve the status.
Understood. Thank you so much, Dr.
Yeah.
Carr. So to summarize our discussion with Dr. Carr, the Champion AF trial randomized 3,000 patients to left atrial appendage closure versus NOAC, and it showed non-inferiority. The left atrial appendage arm showed non-inferiority to NOAC therapy with respect to a composite of death from cardiovascular causes, stroke, or systemic embolism, and showed superiority to NOAC therapy for non-procedure related bleeding. Thank you so much,
Thank
Dr.
you very
Carr.
much. Thank you.